biasalah. You wear your PPE, you introduce yourself, tanya apa masalah, and you assess 5 things kan, bradycardia. Yes, good stability, which is mental status. Encik dekat mana ni? Sekarang ni pagi ke malam, encik tahu saya kerja apa? Okay. Nombor 2, chest pain. Encik ada sakit dada ke tak? Encik ada tiba-tiba sesak nafas ataupun sekarang ada sesak nafas ke tidak? Nombor 4, BP sekarang berapa? Nombor 5, you feel for the cold preference. Tapi kena correlate with the BP lah. Okay, that is number 1. BP 80-40, feel giddiness. Okay, so what is the first line of treatment? Atropine. Dose?
0.5.
Okay, tolong ambil atropine, ambil satu syringe. Ambil yang mana-mana tak? Alright, so you administer atropine 0.5 mg. Okay, 0.5 mg followed by
20 cc.
20 cc. Normal saline. Okay, flush. Okay, no response. So you increase sampai 3 mg. Okay, this is the heart rate not responding. Next choice, what do you have? Sorry? Okay lah, sebelum tu kan you boleh bagi your dopamine. Okay, you start your dopamine, heart rate sama, BP pun not improving. Next, you start your adrenaline. Tadi dopamine, so you have your adrenaline pun tak berjaya juga. Does not even increase the heart rate because tak tinggi heart block. Sometimes pharmacological treatment does not improve. So if your pacing, the pacing dia dah cabut dah ni. Okay, so we put the pad, we attach the pad to the patient. Okay, so still macam biasa, you just need to on the word pacing. Okay, once you push the pacer button, the heart rate will, what is heart rate that you are expected? More than 60. So how much you want to put? 80. Okay, remember if you put 80 and the heart rate now is about 30, berapa banyak? How many times patient will get current? Another 50 times kan? So we start with normal minimal heart rate, which is 60. Okay, 60. Okay, enter you can. Next is your current. Okay, but remember before you give your current, you must tell the patient that it will be initially a little bit painful, but as the current increases, the pain will be more. Okay, so you suggest anesthesia and sedation to the patient as usual. Okay, once patient is sedated, then you check the BP. BP is still at lowest side. You start with current of 10. Okay, do you notice this line? Okay, this is pacing. And how do you know your pacing is successful? It must be followed with QRS complexes. Okay, like this. Pacing followed by QRS, pacing followed by QRS. However, if you see, this one is not successful. It must come with every pacing. The QRS complexes must come with every pacing. So it's not successful, so we increase the current until 20. Successful or not? No. Increase the current. 30. Apa tu? Lucu lah. Successful? No. Increase. Successful. So this is a successful electrical capture. Meaning every pacing followed by QRS complex. Okay, that is number 1. Number 2, there is electrical capture and there is also mechanical capture. Meaning that patient should get the same heart rate. So you need to confirm whether patient get the same heart rate. How do you confirm? You feel for the pulse. Good. Which side you want to feel?
Okay.
Carotid. Okay. I do not suggest carotid because every time pacing, dia mesti ada some movement. Okay, so maybe yang you rasa tu actually is the transmitted movement from the chest wall. Okay, so you have to go to radial or to femoral. Or in another way, you can put in the SpO2 monitoring. From the SpO2 monitoring, you can see the heart rate. Okay, and then you look at the BP. Okay. So first you must get electrical capture, mechanical capture from the pulse, and also you look at the BP. Okay, if everything is normalized, then you maintain. Right? But next step is you need to optimize, because just now you give from 30 to 40. Will 35 will give you electrical capture? You don't know, but you have to try. How you reduce by 5 is by use this dial. If you use this dial, you turun 5. So you try to 35. And we aim the optimum current. So is it successful?
Yes.
Successful. But now you need to confirm with your mechanical capture. Alright, ada ke tak ada? Okay, if the heart rate is as expected, okay, then this is the optimum. You know, if you turun, you go lower down 30 just now, what you did does not. But once patient TCP is just temporary measurement. It might need to be converted into transvenous pacing. Okay, we don't have transvenous pacing, we have to send patient to the cardio center. Okay, from our experience, we have been using this transvenous pacing in ICU, patient with hyperkalemia and severe bradycardia, with urea of 40, 50, creatinine 1000 or more. So it's a reversible cause. Okay. So this pacing, so we send the patient with the pacing into the ICU. So they did the dialysis. Once the heart rate is more, then the pacing will stop automatically. Because this is demand pacing. This is on demand, meaning if needed. So because just now we put the rate at 60, if patient's heart rate is more than 60, it will not give current. Let's try. Let us try. We try to increase. And whether it's working. In real life, it's working. Tapi ni sebab dia kita test. Final. So is there any more pacing? So there's no pacing, no more pacing. Because the heart rate now is 80, I put it as 80. Alright. And so it's quite safe. In sense of if the reversible cause is treated and patient gets the normal heart rate, the pacing will automatically stop. The pacing balik. But sometimes dia dah pace. But sometimes the electrical capture, dia ada miss electrical capture. Meaning you need to increase. So patient need close monitoring.